Good afternoon. Good afternoon. I would like to thank the College of Rheumatologists for giving me this opportunity. Today, my presentation is about a female who presented female with axial spondyloarthritis. So let me begin with the case history. Our patient is a 38-year-old housewife, mother of 2 children. She is diagnosed to have axial spondyloarthritis in 2013. She presented with worsening back pain and abdomen. This time she had a relapse of inflammatory type low back pain and neck pain, together with left-sided shoulder pain and knee pain. There were no small joint pain, no fever, loss of appetite or loss of weight. And she also had abdominal pain 2 weeks duration. It was a right hypochondrial.
Yeah. Hello. You have not shared your screen, I think.
Is it?
Yeah, that's fine now. Yeah.
So I'll start with the history again. Our patient is a 38-year-old housewife, mother of 2 children. She's diagnosed to have axial spondyloarthritis in 2013. And this time she presented with worsening back pain and abdominal pain for 2 weeks duration. It was a relapse of inflammatory type low back pain associated with neck pain. And she also had left-sided shoulder and knee pain. But there were no small joint pain. There were no history of fever, loss of appetite, or loss of weight. And she had abdominal pain for 2 weeks duration, which was a right hypochondrial pain of gradual onset, had an initial discomfort, but it gradually worsened. It was associated with abdominal distension, but there were no Initially, she was treated with NSAIDs, and then she was started on infliximab in 2017 due to the poor response to NSAIDs. Currently, she is receiving Golimumab every 3 months, subcutaneous injections, together with methotrexate 12.5 milligrams weekly. And the last dose of Golimumab was given 3 months before the presentation. She also had severe endometriosis, and she was on monthly progesterone injections for the past 1 year, and the last dose was given 1 month before the presentation, and she was amyloidic since the commencement of these injections. When she presented when she developed this abdominal pain, she thought it was due to her endometriosis, and she has gone to her routine gynecologic clinic, from where she was started on oral contraceptive pill. That was 10 days before the presentation. But she did not feel any improvement of the pain, but rather she experienced worsening of her symptoms. Her past surgical and the allergic histories were not significant. She has undergone 2 pregnancies which were uncomplicated and delivered children vaginally. There were no pregnancy losses. She was a housewife and mother of 2 children. This time she could not attend to her activities because of the severe pain and resultant immobility. On examination, she was febrile, not pale, not icteric. She did not have lymphadenopathy or in skinny rashes, but there was significantly tender hepatomegaly. She did not have any splenomegaly or in free fluid. Her vital parameters were stable, so the cardiovascular, respiratory, and the neurological examination was normal. In the musculoskeletal examination, she had diffuse spinal tenderness in the cervical, thoracic, and lumbosacral area with reduced range of movement in the cervical spine. And the Schauber's test was 13 centimeters. There were tenderness over bilateral sacroiliac joints. The Faber test was also positive bilaterally, and she also had shoulder joint tenderness on the right side with full range of movements. Her BASDI was 6.1, indicating high disease activity. So the problems that we identified were she had a flare of her axial spondyloarthritis, and at the same time, she also had abdominal pain and distension with a tender hepatomegaly, and we were looking for a cause. So we move on with the investigations. Her full blood count showed features of inflammation. The WBC count was 14,000, which was neutrophilic. The hemoglobin was marginally on low side, and the platelets were 555. Blood picture showed features of inflammation. Since that was a COVID-19 prevalent period, we did a screening rapid antigen test, which was negative. Her ESR was 104 and CRP was 42. Both were elevated. Her liver enzymes were elevated, but it was less than 3 times the upper limit was of normal. AST was 110, ALT 92, with some rise in ALP and gamma GT. But her liver functions were normal. Albumin, the total proteins, everything was normal. And the bilirubin was also normal. Her renal functions were normal, so was the coagulation parameters. Because of the severe tenderness, when compared to the elevation of liver enzymes, we thought of doing an ultrasound scan of the abdomen with hepatic vein Doppler, which showed mild hepatomegaly with fatty liver changes, and there was absent flow in the right hepatic vein, hepatic veins, which was suggestive of hepatic vein thrombosis. So we found the cause for her abdominal pain, which was due to hepatic vein thrombosis. So in the management, we immediately started her on anticoagulation with the inputs from my hematology team. She was initially started on subcutaneous enoxaparin at therapeutic doses and later converted to warfarin. And for the treatment of her axial spondyloarthritis, we started on NSAIDs and physiotherapy. And we were afraid to give Golimumab at the initial stage when she was in pain and also when she had alteration of liver enzymes. When those improved, we gave Golimumab about on day 5 of her admission. So we also arranged thrombophilia screening for our patient. LDH was almost normal. And we also arranged active mutation, sickling test and Hammond's test. All the tests were negative. And the antiphospholipid screening was also negative in our patient. I will briefly tell about hepatic vein thrombosis, which is also known as the Budd-Chiari syndrome. It occurs due to the obstruction of hepatic venous outflow, starting from small venules up to the inferior vena cava. So the causes are thrombosis and malignant and parasitic infiltration. It could present in the acute stage symptom onset within weeks. Patient can present with abdominal pain with a tender hepatomegaly. In subacute presentation, they can have prominent ascites and jaundice. In chronic states, they present with cirrhosis. So these are the causes. Most patients have it's due to idiopathic cases, and sometimes thrombosis. The causes are pregnancy, birth control pills, and paroxysmal nocturnal hemoglobinuria and polycythemia rubra vera, well-known associations with Budd-Chiari, which is why we did those screening tests in our patient, and also compression due to malignant infiltration and other causes. And important systemic causes are Behçet and inflammatory bowel disease. So diagnosis is initially done by hepatic vein Doppler, which can also confirm the diagnosis, but further information can be gained by CT scan or MRI scan. Liver biopsy is also used in few patients. For the treatment, anticoagulation is continued lifelong. Have to look for a secondary etiology. Angioplasty and stenting done in some patients, those who have features of liver failure, and liver transplantation in cirrhosis. So why did our patient develop hepatic vein thrombosis? We thought we identified several risk factors in her. One could be due to ongoing inflammation, and second could be due to the hormonal contraception that she was using. And what's the role of Golimumab? So several immune-mediated inflammatory disorders are linked to thrombosis. Examples are SLE, polymyositis, even ankylosing spondylitis is also associated with thrombosis. There is a significant increased risk of thrombosis in patients with axial spondyloarthritis, causing high morbidity and mortality. And both arterial and venous thrombosis are associated. And it appears to be related to the high inflammatory burden of these patients. So if I just describe the pathophysiology, it can be explained by a Virchow's triad. So there are cytokines like interleukin 6, 8, and TNF-alpha, which are key mediated in the immune response in these diseases. These cytokines can activate the coagulation cascade by inhibiting the fibrinolytic pathways. This process is further augmented by the endothelial dysfunction, which occurs as a result of chronic oxidative stress. Furthermore, when in active disease, these patients are immobile, which is another risk factor causing venous stasis. So all these create a thrombophilic status in the body, making at risk of thrombosis. So there are a few studies done on the risk of venous thromboembolism in patients with axial spondyloarthritis. Even though it's a well-known association, the occurrence is rare, therefore the exact prevalence is not known. But the risk is increased about 1.6 folds in these patients, and it is mostly seen in the first year after diagnosis. Usually it is seen in patients who have other conventional risk factors. So what about the role of hormonal contraception? Usually this risk of thrombosis is greatly related to estrogen. Therefore, oral contraceptive pill is a well-known association. But usually the onset after initiating OCP is about 3 to 6 months. But if the thrombosis occurs early, we have to suspect underlying thrombophilic status in the body. Progesterone-only contraception is considered safe, but there are reported cases of thrombosis even with progesterone-only contraceptive preparations. So what's the role of Golimumab? Exact role is not known, but since this is an anti-TNF treatment, theoretically it should reduce the occurrence of thrombosis by suppressing the inflammation. But if we take the BNF, it is mentioned as an uncommon side effect under Golimumab treatment. What about the association of ankylosing spondylitis and antiphospholipid syndrome? It is observed that Antiphospholipid antibodies are observed in some patients with ankylosing spondylitis. But the exact role of these antibodies in these patients is not known. Although the antibodies are frequently observed, the clinical correlation is not yet known. There are a few case reports where antiphospholipid syndrome is associated with axial, both radiographic and non-radiographic axial spondyloarthritis. So in conclusion, a patient who developed hepatic vein thrombosis in the background of a disease flare while receiving Golimumab treatment, she had multiple risk factors for venous thrombosis. But hepatic vein thrombosis is never reported in literature in association with axial spondyloarthritis. Therefore, I think this case is an important case. It's important to keep in mind that it needs a high degree of suspicion to detect these unusual thrombotic events because these are associated with inflammatory diseases. So I would like to thank my consultant, Dr. Duminda Munidasa, for the support and guidance given me throughout this period, and also our patient for giving the consent to present this, to do the presentation today. Thank you.
Thank you very much, Maheshika, for the excellent presentation. I think, Doria, it is a very interesting case. So if the audience needs any clarification, they can, this is the time. Can I ask you one question, Maheshika? Yeah. So now in future, like now she is going to be on warfarin for a long time. So if she gets a flare up, like of anky or spondyloarthropathy, like if she's on Golimumab, hopefully we will get Golimumab continuously. But if not, if she gets flare ups, then we will have a problem in giving her NSAIDs, won't we?
Yes, sir. But at that time also we continued, even though with caution we continued. But of course we will have problems with continuing treatment, sir.
Especially if we get Golimumab, it won't be a big issue. But if we don't get Golimumab, then we run short of options of treating her spondyloarthropathy, isn't it?
Yes, sir, definitely.
Right. Thank you again, Maheshika, for the lovely presentation. I wish you all the best.
Thank you, sir.
Can you stop sharing, Mahesh? Right. Okay. So we'll move on to the next speaker. So today our next speaker is Dr. Madhura Adhikari. He's consultant rheumatologist at District General Hospital, Avisavela. He's going to talk us about a young adult patient with scalp nodule. Over to you, Madhura.
Thank you, sir. Good afternoon, everyone. Thank you very much for the introduction. First, I would like to thank the College of Specialists in Rheumatology and Rehabilitation for giving me this opportunity to present this case. Today I'm going to present quite unusual and less well-reported case. However, I believe this would be an important case for particularly for the rheumatology SRs and rheumatology trainees. So I'll move on to the case straight away. Okay, this is a 17-year-old male patient who was otherwise fit and healthy, and he noticed an enlarging mass lesion, particularly specifically over the frontal temporal scalp area. So initially it was quite small and painless, and he did not have any symptoms. However, over the weeks, it enlarged and become a little bit harder on palpation, and also some tenderness over there. Symptoms were quite not very impressive, like she had mild headache, which is very localized. However, the lesion looked pulsatile on palpation. So this is an enlarged view of the lesion. It's over the scalp of the temporal and frontal area. So it's a palpable lesion.
Madhura, can you please do the full screen?
I am on full screen, madam. Can't you see?
No, we can't see Madhura.
You have to
slides are not
screen
moving.
share that. Slide share that. Slide show that.
Slide.
Can you see the slides now?
No.
We can see the slides, but not in full screen.
Yeah.
No.
Now, can you see the slides?
Can,
Yeah, we can see the slide is considering.
Sorry. Can you see now?
yes.
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 Yeah, that's fine.
Correct.
Yeah, sorry. Yeah, sorry. So, the considerations would be like, of course, this is a pulsatile lesion, so aneurysm comes first, either congenital or acquired later on. An AV malformation is another possibility, and some kind of systemic vasculitis of this age is also a possibility, and a trauma, previous trauma, which also can cause an AV fistula is also a possibility. These were the initial thoughts on this presentation. So, so move on to the more clinical symptoms and signs. The patient did not report any temperature. It's been afebrile. The vital signs like blood pressure, respiratory rate, and heart pulse rate and character were normal. Apart from the mild temporal headache with scalp tenderness, there was no significant physical signs. The pulsatile nature, of course, suggested this could be vascular in origin. Patient did not report any visual symptoms like visual disturbance, red eyes, or visual blurring. And there is no significant previous trauma that could give rise to some kind of a lesion. That's area. There was no such traumatic history or any other medical history of any significance. So the initial laboratory study showed some elevated ESR. It was not very impressive, but significant. It's 28 for this young patient. And the CRP was also elevated. However, full blood count was not significant, did not reveal any anemia, the white cell counts were normal. Urine electrolytes also normal, and some immunological studies were done, particularly ANA and rheumatoid factor, they were also normal. So considering this presentation, an ophthalmic evaluation was done. However, it did not reveal anything significant. And then the CT vascular imaging, CT angiogram showed significant findings, like it is an aneurysmal degeneration involving the right superficial temporal artery. However, the same study did not reveal any vascular involvement in any other territories like extracranial or aortic or any other or elsewhere. So it was decided to excise this lump, the mass lesion, and go for a biopsy. So it was done under local anesthesia. It was a aneurysmal section was resected, and it underwent histological evaluation. Sorry. And this evaluation showed some interesting findings. It is in favor of subacute temporal arteritis. Particularly, it has some multinucleated giant cells, which was more consistent with the above diagnosis, although other inflammatory cell infiltrates were quite non-specific, like lymphocytes, plasma cells. And also, it did not reveal any eosinophils. So the histopathological impression was this is subacute temporal arteritis. Yes, so this is the histological image. It showed intimal layer hyperplasia, the scattered lymphocytes, and some enlarged giant cell you can see. So multinuclear giant cell, which is more inconsistent with the giant cell arteritis. So the diagnosis of classic temporal arteritis in a young patient was considered in this case. And patient was given a trial of corticosteroid, very good high dose of steroids as we give in usual giant cell arteritis. So unluckily, the patient was responded very well, and it was tapered over the next 3 months after the 6 weeks of high dose treatment, and the symptoms was significantly improved, and his headache disappeared, and there was no relapse of the same lesion or any other lesion elsewhere was noticed over the next 18 months. So it was considered that's well responded for steroids and the surgical resection. So I would like to dig into more into this relevant literature of this quite unusual condition, particularly at this age. So as we know, the classic giant cell arteritis is a very rare below 50 years, and even the classification criteria defines it. It is one criteria is actually it should be more than 50 years. However, in clinical context, it's obvious that most of the patients are more than 60. In literature says more than 95% of patients are more than 50 years. So it is an extremely uncommon case in this age group, particularly under 40 years. So however, there are some literature or low-level evidence and case report and expert opinion level evidence available about this type of temporal arteritis in the young. So there are few entities were described. The first thing, like in our patient, is the classic giant cell arteritis variant of the young. Here it's considered as less than 40 years. In this case, the pathophysiology, histopathological and clinical causes are more or less similar to the usual adult variant, and the treatment also the same. They will responded for steroid. It is the rarest, very extremely rare entity. And the other entity is like juvenile temporal arteritis. This is somewhat different from the classic one. It does not demonstrate like same histopathological features. However, usually it does not cause any any inflammatory response as well. It is considered as a benign condition, and it's often self-limiting, and there is no particular treatment is indicated. However, again, I would like to highlight here that these are very, less well-reported cases, and these recommendations are based on very level 4 evidence and like expert opinion. So there are a lot of things to be case-by-case approaches needed when going to these, when making this diagnosis. The other thing is like temporal artery involvement in any other vasculitis, like ANCA-associated vasculitis or polyarteritis nodosa or any other vasculitis that can be occur and well reported in less than 40 years of patients. So this is the third category. So these were the kind of temporal arteritis involving patients in young patients. So I highlighted the same details in the different diagrams. So we are dealing, our case is like the classic giant cell temporal arteritis of young. So more details into this entity. This is, like I said, extremely rare, and in the latest literature says it's only less than 20 cases reported of this classic form of young onset giant cell arteritis. Even histology plays a very important role in the diagnosis. Again, still it's challenging. So as I explained earlier, the multinuclear giant cells are characteristic, but again, it could be rare or sometimes not seen. This is somewhat contrast to juvenile temporal arteritis. It showed mixed inflammatory cells in the biopsy, sometimes with eosinophil predominance, but usually not giant cells. So it gives some differentiating value with the classic form and the juvenile temporal arthritis, which is a benign condition. Again, I am highlighting the same multinucleated giant cell appear in this the biopsy of the above patient. So the management principles were the same as for adult GCA. As I said, the steroid is the mainstay. Like our patient was well responded for the high dose of steroids and a maintained remission. And juvenile temporal arthritis is considered a benign and usually self-limiting. Sometimes they offered surgical resection. However, recurrence have not reported in this category, and steroids is not indicated. In the third category, of course, we should treat according to the underlying cause. Like, for example, ankylosing is there, so the treatment is the standard treatment of the underlying condition. So the take-home message or the key points here is the temporal artery vasculitis is a very rare but reported reported events in the age of 40, and among them the classic GCA variant of the young is the rarest form with very few cases. And the diagnosis and treatment should be on case-by-case basis based on the patient's clinical presentation, laboratory studies, imaging, and histopathological studies. So I understand this is not I'm not sure whether any of us have have seen these type of cases. However, I believe this would be worth for the senior registrars and rheumatology trainees. If they are although rare, it would be an important clinical scenario. So yeah, I would like to conclude my presentation. I'm happy to answer any questions if the audience have.
Thank you for the excellent presentation, Dr. Madhura. Do we have any questions from the audience? So I have one question. So usually in adults we treat for longer, like for about more than 1 year actually. So this patient was only treated for 3 months. Is that correct?
Yes.
So
Correct.
yeah, because it's is that the way we treat so these young patients?
Yeah, it's a difficult to answer because this is a very rare condition that no one knows what should be the exact treatment. However, one consideration would be that the lesion was more or less completely excised, and patient has well responded, and the inflammatory markers were responded. So that treating clinician might have decided to taper based on those presentations. So again, like I said, it should be case by case. We can't have a blanket guidelines because these are very rare entities. So that should be the way to go, I guess.
Yeah. Any questions from the audience? Right. In the absence of any questions, so I would like to conclude the session. So once again, I want to thank Dr. Madhura for the excellent presentation. And yeah, so we'll conclude and we'll meet next time.
Thank you.